So if there's someone that really, really, really doesn't want to get pregnant, would there be something that would have perfect 100% efficacy for preventing unwanted pregnancy?
No.
Abstinence, maybe? Maybe not even that.
So I guess we can go back and talk about some of the nuance around this, some of the pros, perhaps.
Mm-hmm.
So I thought this was a great one. Will this prevent unwanted pregnancies?
Yeah.
And isn't that a good thing?
I certainly think so. Like we alluded to earlier, one of the biggest health benefits that on your balance scale of benefit and detriment outweighs everything else is being able to not conceive or conceive, basically having reproducing at the time of your life when it is best for you. That's also best for the baby and society, and that's good. We mentioned that different progestin-only pills had different efficacies. It's likely around 98% efficacious. So about 2% of time with typical use, you have pregnancy, even if you take the pill with typical use. Some studies show as low as 0.3% pregnancy rate with perfect use. So 99.7%. And yes, I do know of plenty of cases where there's quite good use and there is still pregnancy. So if there's someone that really, really, really doesn't want to get pregnant, would there be something that would have perfect 100% efficacy for preventing unwanted pregnancy?
No.
Abstinence, maybe? Maybe not even that.
It's just like if you tell someone, move more, eat less, you'll lose weight.
Mm-hmm.
Be abstinent, you won't get pregnant. The prescription for abstinence is definitely not 100% effective.
Mm-hmm. Yeah, a life where, and even if you're married, then you're probably not going to want to only have intercourse the one time that you want a baby. I mean, how boring would that be if you had a baby the first time that you had intercourse and you're like, well, I guess we can't have intercourse again until you want another baby. To wait 2 years.
I guess you've got your 9-month window there. And then, you
that's true.
A long waiting period
that's
after
true.
that. Yeah.
Long waiting period. So anyway, drospirenone, which is another prescription, which is an anti-androgen, it's spironolactone-based rather than nandrolone-based, has a slightly better efficacy. I don't know if it's clinically significant, but a 1.8% instead of a 2% pregnancy rate. So,
yeah, and if we're looking at the majority of the population again, so women who are overweight or obese are more likely to have these sort of, I don't know what to call them, a breakthrough pregnancy.
Especially more than 200 pounds.
Yeah, because at that point you do need a more potent, often higher dosed oral contraceptive to get the same contraceptive benefits. Mm-hmm. So it still sounds relatively good. Even with typical use, you're looking at somewhere between 90 to 99+% as far as the effectiveness, but it's not 100%. So people should not expect to not get pregnant. It's just very unlikely that they would.
Yeah. Dosing is another thing that we looked into pretty significantly. It was interesting to see that compared to the Plan B pill, which is kind of the same medication at a different dose, I believe it was 17 times less.
Depending on the dose you're looking at. If you're looking at the 1.5 milligram levonorgestrel pill, then you could take, what would that be? Basically 4 of those twice, 12 hours apart. So you take 4 Opills in the morning, 4 Opills that evening, and you've essentially recreated the Plan B, one of the Plan B pills. Yeah.
And technically you can also do this even with combined oral contraceptives, but you just get terrible nausea and vomiting and feel horrible from all the estrogen. So it's much better to use a progestin only, and obviously talk to your doctor. That's not medical advice. Another thing that we were looking at is which percentage of enantiomer, and what we mean by that is this is norgestrel. So norgestrel is made up into a right-handed molecule that's usually called the dextro side, and then the levo side, left-handed molecule, kind of the same. And the levo one is the active one that's working.
Just like how dextroamphetamine is just a placebo. It doesn't really do anything, right? Not all dextro isomers are created equal.
Dextroamphetamine is very dopaminergic. So Adderall is a mixture. Brand name Adderall is actually 75%, I believe. 75% dextroamphetamine, 25% levoamphetamine. Levoamphetamine is a bit more adrenergic, specifically with adrenaline or epinephrine, and also noradrenaline. And dextroamphetamine is more dopaminergic, dopamine. So there's a mixture of two, 75%, 25%. So it's more dopaminergic. Generic versions of mixed amphetamine salts are not necessarily 75%, 25, anywhere from, I think, 55, 45, all the way up to that. So you don't really know what you're getting. It's a mystery mixture. And then, of course, things like,
blend.
Like dexedrine, lisdexamphetamine, those are pure dextro enantiomer. So we looked up, and the only source we found was on Wikipedia that said it was going to be 50%, 50%. But we don't really know what the mixture will end up being.
Yeah, that's a source, but not necessarily a reliable source. Yep. But it's an interesting pattern that you see in drug development. And even with norgestrel, this same pattern happened. They got rid of that dextro isomer, and you had levonorgestrel, which is where basically all of the data that we pulled together for this came from. It's all based on levonorgestrel because it really wasn't terrifically popular. I think it was discontinued 2017 roundabout. Another company acquired it, and now they're bringing it to market. In reality, they could have just used a levonorgestrel product, but there's probably patents and things like that prevent them from doing so.
Yeah, slightly tweak it and then make more money. The supplement and pharmaceutical industries love doing that. I guess while we're talking about benefits, we should talk about things other than preventing pregnancy. As people that watched our synthetic HRT podcast know, each of these progestins and really any hormone, you have to look at multiple receptors. So the receptors we have listed, the progesterone receptor is obviously an agonist at the progesterone receptor. And you can look up the receptor affinity as well. But you can compare it to other mini pills. And we don't have to go extremely in depth with this, but Micronor is a commonly prescribed one, especially individuals who are postpartum. And there's actually pretty significant differences. Even if you look at desogestrel, which is actually what Implanon, Nexplanon, Cerazette, Isobloom also has it in it, but Isobloom's not a mini pill. But basically the progestin that's in Nexplanons is very similar. And if you look up the androgen receptor, it both says positive. So that means it's the same level of androgenicity as the Opill, right?
You would think so based on this chart. And we'll probably recreate these in a more easy to read way for people. But if you actually go up and look at the affinity, the levonorgestrel actually binds more potently to the androgen receptor. So it's a more potent androgen receptor agonist. So it seems like the group that is being catered to with this FDA approval would be athletes.
Mm-hmm. Yeah, that's an apt statement. If you look at another mini pill like drospirenone, it is an antagonist at the androgen receptor, a clinically significant antagonist. Interestingly, as far as like anti-estrogen and estrogen, it is levonorgestrel or norgestrel, is really the same thing. They're positive at both of them. So we were discussing, does that mean that it is a partial agonist, partial antagonist, like buprenorphine, or is it a SERM? Or both?
Yeah, it's a question that I don't think we have an answer to as of yet. So maybe we'll find that out when we do our family tree of synthetic hormones, synthetic estrogens and progestogens.
Yeah, anabolic steroid family tree, estrogenic steroid family tree, progestogenic steroid family tree, all on the horizon. If you happen to be, again, like a PhD in pharmacology or a PharmD that is really into pharmacodynamics, please listen in or even shoot us a message. We'd love to hear your thoughts on things like this. The next one that we wanted to mention is agonism at the glucocorticoid receptor. So you think of prednisone, you think of cortisol, your endogenous glucocorticoids. And among progestins, there's actually a huge difference in whether it's positive or negative. You were mentioning, I don't remember if it was
Megestrol.
Meg-ACE. Yeah. is certainly a glucocorticoid receptor agonist and is associated with weight gain, whereas norgestrel is technically an antagonist, but I think completely insignificantly, whereas desogestrel is just a bit of an antagonist. Think of a similar effect to anabolic steroids like, I believe, nandrolone and oxandrolone are, I don't know if they're direct glucocorticoid receptor antagonist or if they have a satellite interaction. So I don't know if they're a ligand or if they allosterically alter it, but it reminded me of that interaction, which is an interesting potential benefit. Let's say someone has Addison's disease and they're on hydrocortisone all the time, or let's say they have Crohn's and they're on prednisone all the time. There's certainly a secondary benefit to that.
Yeah, and there may even be changes on body weight. We know there's certain medications that are weight neutral, weight positive, or weight negative. If you have something that's antagonizing that glucocorticoid receptor, as you mentioned, that could be weight negative. It could actually be associated with a reduction in appetite and some weight loss.
Yep. So I guess you could look at desogestrel as potentially a good one for someone with Cushing's disease.
Yeah, that would make a lot of sense.
Yep. But, those are rare. So who needs a specific, who needs their, steroid stack designed? Who needs their menstrual cycle designed? I think that's a pretty good summary of the receptor benefits. Again, we'll have a future episode on steroid family trees and dive more into those.